This list goes through, as we can see here, family history, the hypercholesteremia not qualifying for heterozygous FH, metabolic syndrome, chronic kidney disease, again, the inflammatory arthropathies that we mentioned earlier, and then the conditions related to pregnancy or early menopause, and then high risk. And so I think I've almost got this memorized. We'll go over it one more time. Okay, and then including the additional risk enhancing factors of elevated C-reactive protein. I'm most excited about lipoprotein a being included as this has been an important laboratory test in patients that have normal appearing lipid panels, but they have a strong family history of early strokes or heart attacks. It's nice to see this included as something that can be tested for. And then ApoB is a little bit more controversial as to whether or not it adds additional value, but there are clearly trials that show that it does add more stratification above and beyond a standard cholesterol panel. And ApoB is just a way of measuring the more atherogenic components of LDL cholesterol. Okay, then as far as implementation, the new guidelines include all of the things that we would expect in our day and age, with telephone reminders and integrated multidisciplinary educational activities, pharmacists. And I think that from my perspective, if we truly integrate these guidelines the way that the guidelines have given us on the high end, we could certainly add a lot of resources to the current levels that we are using now. And then the last thing I want to point out on here is just this huge emphasis on the most critical part, which is this patient-clinician discussion to promote all aspects of the treatment and to make sure that there's a clear understanding of not only the risk factors, what you're treating, the side effects, potential costs, and to include the patient preferences. Okay, we have 10 slides left on the ACC-AHA slides, and these are the 10 take-home messages that the guideline, that the ACC-AHA leadership wanted us to take home. So, I've already mentioned this is what I want you to take home from the conference, from this lecture today, is that lifestyle is included, and it's also included in the monitoring, and it is
on the back of your agenda.
Oh, great.
You have this as a take-home. Yeah, as a tattoo.
So, whether or not you're talking about the pediatric patient, where you're emphasizing diet and lifestyle as a way to prevent even developing the risk factors for cardiovascular disease, whether you're talking about someone who has already developed atherosclerotic disease, the emphasis on including lifestyle can't be overemphasized. It's prominently featured in these guidelines. Next, then, is that if somebody has a presentation with atherosclerotic disease, this is to emphasize that targets are back. That we want to shift away from the guidelines of 2002, where we focused on a number at the starting number, as being, or actually the cholesterol number as being the risk. What we're now focusing on is we're looking at the patient as being the risk. So if their cholesterol started at 90, but they've had a heart attack, then you want to aim to 45. You want that 50% reduction. It's more a focus on the reduction, and then also a target. And then this is the next point, is that in addition to the 50% reduction, is that you want to get down under 70 in high-risk patients. And to do that, if it means adding ezetimibe or PCSK9 as the primary additional agents besides a statin, then that's important to do. And so we'll avoid the controversy about the cost and the long-term PCSK9. That was easy. The other take-home message with familial hypercholesteremia: don't calculate their risk, just treat. And this makes it much simpler for the occasional FH patient that just based on traditional calculators. Okay, and then as I've already mentioned, if you have diabetes, straight to treatment, and then potentially if you're even at higher risk, based on the risk enhancing factors, you may want to go with high intensity. And then again, aim for a targeted reduction, both in percentage and in numbers. And then this is again to emphasize the fact that we should be including the risk factors and the risk enhancing factors, which will be in another slide here. But for someone who's 40 to 75%, that you want to have, or 40 to 75 years old, for primary prevention, you want to have these risk discussions all the way through to include the risk enhancing factors, like the benefits of lifestyle, as well as the medications, and then the full informed consent or shared decision making that is core to the, is at the core of these new guidelines. If after having the discussions with a patient that is in this category of 40 to 75 with an intermediate risk, there's still an uncertainty as to what to do, then as we've already pointed out on the primary prevention scheme, then the CAC score can be included.
Please don't use acronyms for those who don't necessarily know the meaning.
Sure. So if after going through the intermediate risk patient and you still haven't reached a conclusion with the patient whether or not to use a statin, adding a coronary artery calcium score may be of value. And the important thing may be that it actually may point out that they don't need treatment if it's zero. I mentioned that we were going to go over this list of risk-enhancing factors several times today. Still trying to memorize it. Just here again, emphasizing the importance of looking at these risk-enhancing factors. And I think that, to me, this is something the guidelines have done really well, which has just given us more opportunities to be able to identify people and escalate the therapy rather than just looking at the calculated risk score. And then the additional risk-enhancing therapies, the list continues to include the laboratory values as well as peripheral arterial disease. And again, taking home the point that coronary artery calcification scores can be of importance, especially if there's zero without smoking and without diabetes, that you could consider delaying or treatment or deferring it for some period of time. And then lastly, the point is that as I mentioned at the beginning, that we are now, these guidelines shift us from focusing just on the response to medication, but also to the response to lifestyle, and that having these discussions with the patient up front so they understand that when you have the serial monitoring, that you're measuring the combined effect is, I believe, an important component of the new guidelines. And now, just to take a couple of minutes to talk about coronary calcium. As some of you know, I worked in flight medicine with military pilots, and we use this as a key tool in developing risk identifiers for our military pilots. And used in the way that we used it with what I call high reliability science, we were able to identify and protect the safety of flight. And this was also, the same knowledge was used with astronauts as well with NASA. And then the military, especially the Army at Walter Reed, started offering this for retirees. And last year the data was published on this, that military retirees, approximately it was 14,000 of them that were followed over a decade, were shown to have benefited by identifying the coronary calcium and the subsequent treatments that ensued, whether it was primarily a statin, but we speculate that, of course, they may have benefited from additional lifestyle changes as well. And the important thing that I like to emphasize about a calcium score is the score itself doesn't change anything. What matters is how that score is presented to the patients and what happens after that, whether it's treatment. And the advocates of coronary calcium scoring for years have said that we should get more successful outcomes, and I think now the data is starting to show that. And I think that the inclusion in the 2018 guidelines is a validation of that, at least for the intermediate risk patients. And the concept is quite simple, that if you have more calcium, you're at more risk, and therefore we should escalate therapy for you. And if you have no calcium, we can consider completely deferring therapy. And so the question comes up as to why are we now several decades into coronary calcium scoring, and it's only being included in a small way in the new guidelines. And I think at the same time that in the military we were using coronary calcium scores in such a successful way, I think in the civilian world we had a situation where coronary calcium was immediately put out into use with overpromises and just frankly profiteering. And it's always interesting in the scientific community when skepticism sets in, because it can take decades to overcome that. And I think that's the situation we've been in. One of the other interesting things that gets pointed out about coronary calcium scoring is that when it comes to research, it was an additional cost if you were going to include it. And so researchers preferred having things like the Framingham score, which you could calculate for free. And there are experts, Valentin Fuster as one of them, who has mentioned that he believes this was one of the reasons for the delay in the acceptance of coronary calcium scoring, was that it required additional work both for researchers and clinicians. And then the criticism about radiation and possible incidental findings, primarily more for coronary angiography, but the test was often included in the same study. The coronary calcium score was part of the same study. And so I think that, in a sense, the 2018 guidelines are representing a second chance for coronary calcium. At a time when the attitudes are changing, we have now respectable trials coming out in major journals showing the benefits of coronary calcium, and the problems with the testing have been pretty much not validated. I'm hoping that this is a reset in our thinking, and that having the coronary calcium being used in that intermediate segment will give us a chance to expand it to a much larger audience of both physicians and providers, as well as to patients and the general public, and that it will hopefully be validated. I think that inclusion of the lipoprotein little a and the ApoB and the high sensitivity CRP are an illustration of the National Lipid Association's influence, and that it was a small step in including other testing that can be of value. As I've already mentioned, I'm most excited about the lipoprotein little a because I think it offers a huge value for those patients who were otherwise completely missed by traditional testing. And I just want to take a second to illustrate why I think that including the ApoB and the lipoprotein little a can be of value. Many of you have probably seen this, where when we look at patients that have cardiovascular disease and we look at LDL measurements, the overlap between no disease and disease is very difficult to distinguish that just on LDL alone. And so this is why the National Lipid Association for a long time has been advocating for additional testing besides LDL.
So it's sort of a triangulation method. It's more detailed precision medicine. It's not that LDL is not important, because every cardiologist that's ever presented has presented how low their LDL is. And you don't have to reveal what yours is, but you're not saying that LDL is not important, right? Because the guidelines are now saying keep it under 70 for those who are very high risk.
Correct, and whatever your starting LDL is, reducing it 50% plus under 70. But the point being that there are clearly abnormal LDLs to the right over there, where you have someone with disease and a high LDL, and then there are LDLs in the middle where you may or may not have disease. Your LDL will not help distinguish that. This graph probably shows it a little bit better. In patients presenting with coronary artery disease in a hospitalized setting, the use of an LDL cutoff is not that helpful, because the number of patients that had even LDL under 70 was still 23%. So adding measurements such as ApoB, where you can look at more atherogenic components of LDL, have shown to be more beneficial. This is now my commentary on this, is that if we look at implementing this and doing things like we just talked about, where you do a calcium score or do other labs, this will certainly be an additional amount of resources and time, possibly even a second visit, depending on how well of a pre-screening program you have as to when you bring in a patient to address their cholesterol. And the involving the patient and having the full outlined collaboration that the new guidelines mention, I think if it's done to its fullest, can certainly possibly drive, I need to be more committed in my answer, I think it will drive a need for more resources. I think as time goes by and we get better at this, and maybe if patients become more familiar with the new guidelines, there may be the possibility that we can do it with what we have now, but I think that in the interim, it's certainly going to take more resources. And the same with healthy lifestyle. Handouts alone are not the end of the guidelines. They want you to go to the next step and actually have referral with education and help with achieving the diet and lifestyle. And so that may drive resources. These are just some of the examples of, if you look at things that patients can use, this is what they're supposed to come to you with, is ask your doctor about your 10-year risk score and ask about risk enhancers. So if for those of us that have started seeing patients, I will tell you that these are longer visits than the previous guidelines. And then, yeah, if there's any doubt, ask if a CAC score, I'm sorry, coronary artery calcification score will help. And then the guidelines also point out for the patients that to continue to have these ongoing discussions about therapy and to stay engaged.
Could you just describe why the coronary calcium score is important in the treatment decision? Isn't it because it's stabilizing the plaque?
Let me make sure I understand your question. So if somebody comes out as an intermediate risk, and they, after discussing the risk-enhancing factors, they may or may not have.
Oh, that's in all these years, we've never had a word with us at a RightCare meeting.
That's a bad.
Oh, well, we have the Department of Public Health with us. A door. Make sure that door is open back there, please.
Yeah.
Is he part of the Air Force?
Yes, that's a stealth.
It's a little bit. So if I understand your question.
Does anybody have a good arm?
I think you'll need a net.
Really don't put that guy in here with us?
Yes, there we go.
Close the door. Please close that door. Please close that door right now.
Who's up to that?
You didn't expect that, did you?
Sorry about the drama there, but long ago when I worked in the Department of Health Services, we had a huge bat scare. So, I mean, in terms of a public health scare. So we're really happy it didn't land on anybody.
Let me make sure I understand your question. So after you've identified a patient that has intermediate risk and after discussing the risk-enhancing factors, if a decision is made to pursue a coronary calcium score.
And you have a positive score, why is that important in the outcome?
I guess the way I would look at it is that you've used a test that has an increased specificity for benefit, or it was with coronary artery disease risk, and therefore you're going to escalate your therapy. Are you getting a
Yeah, I don't
serial?
think everybody understands that here. Why, why does it matter if you have a score of 1,000 on the coronary calcium test?
So coronary calcium in the arteries represents healed plaque. And we used to just focus on a number, and now as time has gone by, we've learned to focus on things such as the number of plaque lesions or calcium lesions and the types of calcification. We've now learned that microcalcification is more significant than just large areas of solid plaque. But the coronary calcification represents healed coronary artery disease, and the amount of calcium represents the burden of atherosclerotic formation and healing. And if you have somebody who has a high number, then we look at that as, it's not the coronary calcification itself that's dangerous, it's the plaque formation that can form a acute coronary syndrome that is the problem. And so by treating that patient, you're hoping to stabilize the plaque and reduce the continued formation of risky plaque. Everything else to add?
Yeah, it identifies individuals with a high burden of atherosclerosis, and it's really the soft plaque with the thin cap that's more likely to rupture and create an event rather than something that is calcified, but they go together.
So Dr. Kimberly Buss of Sutter, thank you for being with us. You have a new medical director title that you can tell us about later if you desire, but yes, thank you for being here today.
Yeah, I just have a question. I thought about this a bit, and in the old guidelines, if your 10-year cardiovascular risk was greater than 7.5%, and you're in the intermediary primary prevention group, the recommendation was to use a statin, a moderate intensity or high intensity statin, depending on kind of your risk level. But this new recommendation is if you're in that in between 7.5% or higher, but not 20. So if you're 20% or higher, you go ahead for a statin no matter what. But between 7.5 and 20, you may consider using the CAC or the calcium artery score to make a decision. But it primarily would make the decision not to treat. If it's 0, you don't treat. So the CAC doesn't really increase the amount of people who would have been recommended to take statins. It's the same number of people would be recommended to take statins as before. Or the people, if they had a recommendation before, would have been taking the statins. It's just that this says there's a certain subgroup of people that don't need to take statins.
Correct.
So it doesn't really find more people at high risk to take statins. It says that there is a subgroup of people whom could feel more confident not taking statins, suggesting that maybe their risk is more than 10 years off. And they may need to recalculate their risk a little bit down the road, but they're not. So it almost seems to me it's like it's not something that's increasing people's ability to identify their own risk. It's just identifying some people whose risk actually is potentially very small. Is that your take on it?
Yeah, potentially it would remove about 20% of that group from taking statins.
But the rest, so in the old guideline, they would have been all taking statins.
They would have all taken it.
In the new guideline, only 80% will be taking statins. So
Right.
it's in this new guideline, there's slightly fewer people that would be recommended, because this is only a tiny subset, or it's not tiny, but this is only a subset. So there's fewer people that we recommend taking statins, but it doesn't use the CAC score to identify more people who are at high risk and encourage them to use more statins. They were already recommended to use statins.
They would have been recommended to use a statin, but if they have a score over 100, you really need to use a statin.
So
You've identified an additional way to.
So they would have been recommended a statin in the old guideline, and they're still recommended a statin in the new guideline.
You could look at it that way.
I mean, that's how I took it. Like, it does help us, a subgroup of people choose not to take a statin. But it doesn't really change the recommendation of a lot of them still to take a statin.
In my mind, it does, because you've given them a much more specific and illustrative reason why they should. They now have a known CAC score that identifies them at a particular risk, whereas before you were just identifying it based off of less specific.
Your perspective is that from a patient engagement standpoint, it's the score somehow is encouraging more so than giving up.
And this was the point of the military retiree study that I pointed out with Dr. Todd Valines out of Walter Reed, where they looked at 14,000 retirees that were given a positive score. They benefited with their long-term outcomes because of having that score. Was what they advocated as the results of their research.
But that was really more from a patient engagement standpoint.
That's an important factor, certainly.
Because in the old guideline, it would have been recommended to take a statin anyways.
But
Yes.
would they have done it? How many men do you know that say, I'm not gonna take it anyway? But then if they see the proof, oh gee, right, in my left anterior descending artery, I've got some problems there. You're probably gonna be taking that statin. If it's precision to that person.
Yeah, for many people, it can be very powerful, and I've had patients go both directions. But it gives them something to really hang their hat on, and when they see that, it means a lot more than some of the other factors that we calculate. Yeah.
So it's interesting, it's like, so patients are more, your point being that patients are more influenced by a picture than by
An algorithm,
a risk,
right.
even though they're the same.
They're not the same, right?
Well, they're the
One's
same.
a statistical guess, and one's a yes, you have it or you don't. Because if you get the coronary calcium score, and you have that 7.5 to 20% range, and the calcium score says 0, then your risk is down classified.
So some people won't do the same.
Right, and Matt Budoff testified a couple of years ago here that up to 40% of people who are on statins don't need to be because they have a 0 score. And so I think the more modest, more conservative approach is to say perhaps 20% won't need the medication.
So the calcium score has been deemed a tiebreaker. If you have an intermediate patient
So that
and
suffers.
and the patient or the clinician are unclear as to which way to go, it can come in as a tiebreaker to swing the evidence one way or the other and make them more confident in their approach.
I will just add to that from my experience is that having a test that somebody can't say that's just my average risk, that it's individualized to them, and they know that's their risk based on that calcium score, that it does change.
Kind of affects psychology, is what you're saying.
Yeah. So if I haven't made it clear, I like the new guidelines. I think that they're a step in the right direction. I felt completely abandoned as a provider by the 2013 guidelines. And so I promise I made this slide before the new guidelines came out. This was actually while I was still in Afghanistan preparing a residence lecture. And I think that everything that I had written for the way that I like to practice preventive care is included in the guidelines. And so I have top cover, if you will, by the new guidelines. And especially the part about being able to do serial monitoring for lifestyle as part of why we bring patients back. And then after, of course, they reach their goals, then you can start going back out to the traditional one-year follow-up. But the idea of being able to do it as frequently as every couple of months is something so important in my mind. And that's all I have.
So,
Yeah.
in the past, they used to say with smoking and weight and diabetes and high cholesterol, that explains only about 50% of the risk of coronary disease. That was, maybe, I don't know, 5 to 10 years ago. Now, there's been recognized for probably longer than that, ApoB and lipoprotein A and other factors are major contributors to people's risk of coronary disease outside of all of the other traditional ones. What proportion do you feel now is related to the traditional factors that are modifiable by lifestyle or by statins, and what percentage do you feel are these other things that are outside of that? And are there medications outside of the